one of the things I do, and I'm going to stand behind, not that that's safe, but one of the things that I do is I come along the pelvis and I feel the tubercocci. I usually kind of give a little wrap along here, and I'll go and actually touch the tubercocci, the tubericii, and I'll actually try to tip the pelvis. Now, I'm not moving this pelvis, okay? I'll be the first one to say that, but what I'm trying to do is see if I can cite any problems with it. I'll actually grab up here on the tubersacrum and actually try to rotate this way and just get an overall impression. The one thing about it is, it's the pelvis and its interaction with the sacroiliac that joins the hind leg to the torso of the body. The ball and socket joint is right here, okay? Most people want to think that the femur is coming up over here, and that's what this point is, the point of the hip. The point of the hip is actually just the pelvis. The hip itself, the joint, is back in here. Perfect. So this is the way it actually is in the horse, okay? This is the seat bone, tubercocci, okay? Tubericii up here, sorry, tubericii, tubersacrali. And this is where the femur, the ball and socket joint, comes in, okay? And the leg goes like this, all right? And it sits like this, okay? At your birth canal, okay? Rectal, there it is. And actually, this is good to actually see this. See my really long arms, okay? How far am I actually feeling for these colics? Not very much in terms of the abdomen. So if you're actually having an abnormality that I can feel on rectal, okay, you've actually had a lot of problems that are in the very caudal abdomen. Intestines are all the way up in here. Even, I don't want to say into the chest, but behind the chest. Now this is the sacrum, okay? So as you come down, and Becky did not draw this, the vertebrae are coming along lumbar to sacral, and it sits like this, okay, at this level. And the way this actually sits is just like this, okay? When you look at that from this side, I'll even tip it up, it's really just these two little spots, one here and one here. Those are the sacroiliac joints. It's not a real discrete joint like we think of as a joint, okay? You know, you've heard of horses having a hunter bump, maybe not in the dressage world, but the hunter bump, what that is the pelvis has tipped a little bit, and you're seeing the bump of this tuber sacrali sitting a little bit. Now, so I come down the back, I do my little pelvis kind of fiddling thing, okay, no big deal. It's tough feeling the femur, okay? Very few problems of the actual femur with it. Now I come down to the stifle. I usually am feeling for effusion or swelling of the joint itself. Down our humerus, our tibia and our femur. The hock, there's actually, there's 7 bones, actually 8 bones, but there's actually 4 joints to it. The biggest joint that you guys see and feel is this one up top here. This is where the majority of the motion occurs, okay? This goes like this and this goes like this, okay? All of that occurs here. This is where very little pathology actually occurs. In other words, this is not the joint that we typically inject when we inject our hocks. We're injecting these lower hock joints. Those joints don't flex very much. In fact, maybe a degree, but they take concussive impact all the time. They're your shock absorbers. Our goal in these is to actually, 1, make the horse more comfortable, but 2, to get these joints to fuse. When they fuse, technically they should be sound. The tough part is getting them to fuse. Okay, and there are some surgical things that you can do. They have their pros and cons as well. Then when we get down here, I gotta admit, it's no different than the front leg. Okay, do I see more hind end suspensory injuries with dressage horses? Yes, I do. But I can certainly show you plenty of jumpers that have that as well. So I do think some of the things with our soft tissues, since horses can verbalize and tell us that it hurts, is that they can have a good day and go out and do what you want and then tweak it on the other side just as easily. I'm sure we've all experienced something similar with ourselves that we've done that we can relate to that as well. So I then go along and I'm feeling for all these anatomical structures. I'm going to pick up the leg, I'm going to flex the leg, I'm going to squeeze, rope, do everything I can. On the hind leg, you can bring, most horses should be able to bring it forward, should be able to bring it back, and they should be able to abduct it as well. So my usual routine is I do the left side, go and come all the way down, then I go to the right side and work my way back up. Once I've done that, all I've been able to do from that is just say, okay, what am I feeling, what am I seeing? And is there anything abnormal? In this horse, there's a couple little things. I feel some swelling in one of the fetlock joints. I think there's an old splint on the inside, at least on this left side. Probably all of that's expected to be normal. Okay, now, so far we've done nothing to actually have this horse move. We've just done this at a stance. The other thing which I'm not going to do, but hoof testers. And I find that to be very, very important. The majority of our lamenesses, 75% of them, fetlock or down. I know we always want to think it's in the hip, in the shoulder, maybe the neck. Maybe it is for some of those horses that we have out there, but the majority of them are much lower. Okay? And the nerve blocks that we do show us that. So now the next thing we're going to do is watch the horse in motion. Okay? And I'll give you the simple way that I was taught, and I think there's a lot of different ways of looking at lameness exams, but first you got to delineate, is it a front or a hind end problem? Front end, there's usually some head and neck movement. Hind end, you're looking at butt movement, okay? Then you can get into some of the fancier things of looking at stride length, how far they reach or don't reach, how they land. Some people look at the drop of the fetlock, okay? If it drops more, that means they're putting more weight on it at that point, okay? But I think that's kind of confusing. So the easiest thing for me is to say, do I have a head nod or do I have a hip hike?